Coronary angiography is a definitive test which is performed in the patient of coronary artery disease along with PCI or CABG. It is a test of choice for the patient with the pre-test probability of the CAT. In this, the contrast is injected and the blood flow is seen. So we can check if there is any stenosis, or we can check the extent or location of the disease. Now we will discuss about the treatment of the unstable angina. Unstable angina patients should be stabilized before exercise, stress test or catheterization, as immediate management is very necessary. Initially, in all the patients that come with the complaints of the unstable angina, we will first monitor their cardiac activity. Then we will give him the aspirin to all the patients unless contraindicated. And then we'll give the nitroglycerin as an anti-anginal drug and morphine as a painkiller. In high-risk patient, we will do the coronary angiography or revascularization. These are mostly of the patient which have very bad cardiac activity or which have previous episodes of the unstable angina or MI. So in the management, first we will pause the IV line and then we will give the oxygen supplementation to cope up with the ischemia. Then the potent pain reliever such as morphine is given 5 to 10 mg to decrease the stress. Because if the patient remains in the stress, it will increase his heart rate or the blood pressure, which is not good for the patient. And then we will give the antiemetics by IV such as metoclopramide. The mortality lowering treatment is aspirin, P2Y12 inhibitor, heparin, and beta blockers. These are the drugs which are included in the management of unstable angina. Now we have antithrombotic treatment which includes the aspirin. Aspirin is given as a dose of 325 mg per dose. So it is to decrease the thickness of the platelets. So platelets won't aggregate at the place and there will be no new clot formation or thrombus formation. Then we have P2Y12 inhibitor, which is also of this category, and it includes clopidogrel, ticagrel, and prasugrel. It is seen in the clinical trials that giving aspirin and clopidogrel together for 9 to 12 months is a very good regimen. We also have glycoprotein 2B3A inhibitor, which decreases the platelet aggregation. It includes abciximab, trifeban. Then we will give the anticoagulant therapy, which includes low molecular weight heparin, and it is continued for 48 hours. Its best example is enoxaparin, which is a very commonly used drugs. Then in some of the unstable angina patient, the main problem is with increased cholesterol. So that's why in most of the patients when they come, we will prescribe them the statins and we try to lower their LDL. For this purpose, atorvastatin is used for 40 or 80 mg and it should be started within the 4 days of the acute coronary syndrome. So we have given the oxygen supplementation for the hypoxia for pain control morphine. We will also do the electrolyte replacement therapy, especially potassium and magnesium, so the arrhythmia of the patient can be controlled. Anti-anginal drugs such as nitroglycerin, which is a very famous sublingual drug of the nitrates category used as anti-angina, is used 400 to 500 mg. Oral oral nitrate is isosorbide, which is 20 to 30 mg given thrice a day. Transdermal patches are also available and aerosol forms are also used nowadays. The nitrates do have one side effect, which is the orthostatic hypotension. When the patient stands up from the bed or after lying, he will feel some dizziness or lightheadedness and feels that his blood pressure is lowering, and it is due to the vasodilation caused by the nitrates. But this is reversible when you stop taking the drug. Then we have beta blockers, in which especially beta 1 selective blockers are used, such as metoprolol and bisoprolol. Non-selective beta blockers are not used because they cause extensive vasoconstriction in the lungs. They will act as bronchoconstrictors, which will constrict the bronchioles and cause problem. They increase the blood pressure and they are bronchoconstrictors as beta 2 receptors are blocked, and they can cause cough also, but they are contraindicated in ventricular dysfunction and patients of heart failure. And the side effects of the beta blockers include erectile dysfunction and inability of the heart to increase during its rate in exercise. So this is pretty important when doing the exercise stress test. We should keep in mind that if a person is taking the beta blockers and he is going to undergo the exercise stress test, he should stop taking the beta blockers before 2 or 3 days after talking with his physician. Then we have calcium channel blocker drugs which decrease the contraction. Decrease in contraction will ease with the angina, and it includes dihydropyridone, which includes amlodipine, and it decreases the heart rate, but it's have a side effect is cause reflex tachycardia. Then we have another category of verapamils and diltiazem which act on the SA nodes, and but this is just of less chances of reflex tachycardia, so they are preferable. They do have side effects which includes peripheral edema in ankle, foot and periorbital edema. They can also cause the facial flushing. Then we have the potassium channel activator which include nicorandil and IF channels which are the funny channels present on the SA node which control impulse. And then we have the sodium channel blockers such as ranolazine. Now let's talk about the most important procedure which is the cardiac catheterization. More than 90% of the patient they improve with medical treatment only within 1 to 2 days. If the patient is not responding to the medical treatment, we can do the exercise stress test, and if the ischemia is improved, no need to go for the invasive management. But if ischemia persists still for after 48 hours, we will do the invasive treatment immediately, do PCI and CABG. And additional indications for for percutaneous coronary interventions include hemodynamic instability, vent arrhythmia, new mitral regurgitation, and new septal defect. TII, TIMI score is used to decide whether we will go for the conservative therapy or aggressive therapy. So, if when the patient is discharged from the hospital, we should give him some drugs as a prescription, which includes the anti-anginal drugs to reduce the pain, such as we will give him the anti-anginal drugs such as beta blockers and nitrates, and in antiplatelets therapy, we will give him aspirin. Also, we will give him statins, and keep in mind that statins should be given to the every patient for some time without seeing if we have increased LDL or not. It should be prescribed to everyone. There are some risk factors which should be seen in the patient, or patient should reduce them, such as smoking, weight loss, diabetes, hypertension, hyperlipidemia, HMG CoA reductase inhibitor, which decrease the level of cholesterol, which reduce the level of LDL. So regardless of LDL in all patients, as secondary prevention of CAD, it should be given.